Good morning, everyone. Today my topic was assigned to me, the interplay of neutrophils and ductular reaction in chronic liver disease. I will cover in this cholangiocyte activation, immune cells infiltration, etiology-based pathogenesis due to ductular reaction, biliary senescence, and neuroendocrine role of the cholangiocyte. Cholangiocytes, as you know, are crucial component in the hepatic portal areas for liver homeostasis. Any insult, any exogenous or the endogenous insults or the drug abuse is there, then the cholangiocytes are activating. So first step is that the cholangiocytes for the activating, and they maintain, sometimes they maintain because the small and the large cholangiocytes are there, and they maintain without activation, but once they are activated, then they start secreting the cholangiocrine secretions, which are autocrine and the paracrine also. In the second step, or one of the way of the cholangiocyte activation is that hepatocytes are transdifferentiating and becoming the cholangiocytes and then playing the role in the cholangiocyte activation. Third is that the hepatic progenitor cells are going to the staminization or the proliferation. So these are the three steps how the cholangiocytes are activating. So I will just, because all these things all clinicians know, I am just touching 2-3 slides to make understand the little basic. So in the ductular reaction, as I already told you, that how ductular reaction starts, it starts from the microorganisms, endotoxins, exotoxins, and the drug abuse. And once it is activated, then they release the pro-inflammatory cytokines. Those pro-inflammatory mediators are the IL-8, ENA78. What I will say that these are the epithelial cell-derived neutrophil activating protein, growth-related oncogenes. When these are secreted, they recruit the neutrophils. And once in many diseases, interferon therapy is going on, interferon reduces the IL-8, and instead of neutrophils, they start secreting the monocyte chemotactin protein, MCP1, inducible T cell alpha chemotactin ITAC for the T cells, and CX3CL1 and the MIP3A for the dendritic cells and the Kupffer cells. So it all depends upon that what kind of insult is above. Above insult is if endotoxins or the microorganisms, then the neutrophils recruitment is there. Otherwise, there is a recruitment of dendritic cells, Kupffer cells activation, lymphocytes, I will come back, and then it creates the duct damage and the ECM deposition leading to the fibrosis. What are the cellular components contribute to the ductular reaction? First, self-proliferating cholangiocytes. So these cholangiocytes are self-proliferating and make the ductular reaction. In the HPC differentiation, HPCs are activating and then it converting into cholangiocyte and contributing to the ductular reaction. Or the hepatocyte, as I showed you in the last slide, they are differentiating and making into the cholangiocytes and then contributing to the ductular reaction. So generally what happens any time whenever there is a reactive cholangiocyte, it has, when it is repairing the, secreting the pro-inflammatory cytokines, it has the ability that it will repair or resolute. But there is a background of the host genetic factors, epigenetic mechanisms, and post-transcriptional phenomena. Depending upon this balance happens, and then it goes to the persistence or progression. Then first step is fibrosis, second is cholestasis, and then the malignant transformation. If anything I miss or I say wrong, please pardon me, this is not my area. So what is the role of neutrophils in the ductular reaction? Because if in this picture, that because the bile duct is very close proximity of the duodenum, that's the region biliary epithelial cells are continuous in the accordance with the endotoxins, which is the LPS and the IL-1 and the TNF-alpha. And reactive cholangiocyte, then they secrete lot of it and recruits the neutrophils. Now, just simply, I want to show that what are the facts of neutrophils. Neutrophils are most abundant leukocytes in the blood. They are fast responders in the clearance of invading pathogens, terminally differentiated when exiting the bone marrow, and can adopt a tissue-specific phenotype. So what happens? Recently, people have shown, this is a Hepatology 2023 paper, where they have done a large study of almost 197 patients. They have taken the ALD, NASH, HCV, HBV, and the PBC. MPO is the marker of neutrophil, that is in the red color, and creatinine 7 is the green color. So you can well say that in the alcoholic liver disease, they have found that the proliferation and then the MPO. Then in the NASH, it was very less. In the HCV also, there the MPO was little more. MPO is the marker of neutrophil. And in HBV and the PBC, it was a little. So they said that neutrophil accumulation was in all chronic liver diseases. And how, but they have seen that out of all those patients, alcoholic liver disease has the more, and which has the basic concept, because in alcoholic liver disease, LPS secretion is more, and as I already told you that neutrophil recruitment will be more. However, they have very beautifully, they have made it that in the pre-cirrhotic conditions of the alcohol, compensated cirrhosis, decompensated, and alcohol-related hepatitis. Again, they did the immunofluorescence of MPO and creatinine 7. They have seen that the periportal MPO staining areas, they have covered it, and they have shown that alcoholic hepatitis has the highest, and even the distance is biliary epithelium distance and neutrophil distance. So distance is reduced in alcoholic hepatitis, and in this slide they are showing that, see, this arrow is showing that the neutrophils are sticking to the biliary epithelium. There is, means they are very close proximity of the biliary epithelium. Then in another, this is another manuscript. They said they said that the ductular reaction cell display inflammatory profile and recruit neutrophil alcoholic hepatitis. What they did, they just took the 3 fractions, keratin 7 for the proliferation marker, negative, and the positive. So they took the did the single cell sequencing, and from single cell keratin positive cells, they have found that the HNF beta, creatinine 9, EpChem, which is the marker of biliary epithelium, again the SOX9, though they have taken the composite composition of the proliferative biliary epithelium markers and the neutrophil markers, and in another, in the same study, they did the intravital microscopy. Intravital microscopy is what? Because in this manuscript, they have taken alcoholic hepatitis patient, and then they have fed the mice DDC and further alcohol. And in mice, what they did, they have seen the 0 day before that, what happened, 2 days, 4 days, and 7 days. Intravital microscopy you can do in the live animal, and intravital microscopy gives you that close proximity of the cells, even the molecules, they can see it. And then the immunofluorescence, with the immunofluorescence and intravital, they have shown that the Ly6G, because Ly6G is the marker of neutrophil again in the mice, which is now in the MPO in the humans. So Ly6G was in the central area of the biliary epithelium, in periportal, not the periportal area and the central area. They were on the 7 days, they were all with the close proximity of the biliary epithelium. And these neutrophils, they have seen till 1 week it was there. Now, in the next slide, what they did, they again did the single cell sequencing of those pre-cirrhotic, cirrhotic without AH, and cirrhotic with AH. So, in the controls and in the cirrhosis with alcoholic hepatitis, they have again found that the chemokine marker CXCL6, 5, 8, basically they wanted to show that the chemotaxis is happening, and due to the chemotaxis that there is a neutrophil recruitment. And then they have seen that the KRT7, the proliferative marker, and then they have done the CXCL1, 2, 3, 8, all CXCLs, they have done the R value, and they were significantly increased at the time that where it is the CXCL1, which is a fractalkine also, and it is called as the chemokine 3 ligand also for the neutrophil. This is basically more for the neutrophil recruitment, and then they have shown with the histopathology that the CXCL5 and the troponin 2, which is another molecule for the neutrophils, and the proliferation also it was considered that in alcoholic hepatitis, that when they did the RNA and the ELISA also, they showed that in alcoholic hepatitis, CXCL5 and the troponin 2 was extremely increased in comparison to the control, here the control, but pre-cirrhotic and without AH also, it was increased. So this is showing that they gave the name DRANs, ductular reaction associated neutrophils, are immobilized at biliary epithelium. What they did, how they checked that immobilization, again they have did the intravital microscopy, and in intravital microscopy they tracked these neutrophils, and they found that these neutrophils stayed there, and in fact these neutrophils were for the longer time they were staying, and it was not only the new neutrophil, old neutrophils were there. They did the neutrophil and APCAM positive cells, no injury, because once they have given the injury, and once after the 24 hours, there was decrease in the neutrophil, but it was still staying there. So they declared that the neutrophils acquire an aged and pro-inflammatory phenotype because of the CXCR4. They did in the bone, they did in the blood and the liver. If you can see that in the liver, aged neutrophils were there. And then they did the L-selectin cells also, and again the L-selectin was low. L-selectin is what? It is again the kind of a ligand which is mobilizing or which is taking the neutrophils. So in the liver it was low. It means that the neutrophils are staying there, it's not moving, or from the bone marrow also if it is coming, it's aging over in the only the liver. And they have found that these neutrophils had as I already told you, these neutrophils have the pro-inflammatory phenotype with the more of IL-1 beta, IL-1 production, and the TNF alpha. So it means that they summarized that what happens in any chronic liver injury in the CLD, and when the ductular reaction happens, neutrophils acquire more of CXCR2 and less of CD62 ligands. They acquire more of CXCR4 and start producing the ROS. These producing the ROS, and then they start expressing PAD4. PAD4 is a molecule which has the protein molecule which is for the activation of the many cells, and these PAD4 is increasing, and elastase which makes the neutrophil nets, and these nets again make the ductular reaction proliferation. So this sequence is going on. Once there is a LPS they have seen, this is only with the alcoholic hepatitis more. I am coming again back to the other things. In another study in the manuscript.
Nirupma, just to interrupt you for a second, how does the message from hepatocyte goes to cholangiocyte and then the cholangiocytes alone attract neutrophils.
No, they don't alone.
Go back to the previous slide. I mean, it's a very interesting concept, but if it is true, it should be only for the, cholangiopathies, but from alcohol with the Kupffer cell, I'm still not clear how neutrophils and cholangiocytes cause injury.
Agree. Sir, in the cholangiopathies, when there is a ductular reaction, that is separate story. In the alcoholic hepatitis, we know very well that the neutrophils certainly will come when there is a LPS. So they are saying whenever the LPS is there and the neutrophils start expressing more of the CXCR4 and produce the ROS. Because here the story is only for the neutrophils and they start making the nets. Once they will start making the nets, these nets will influence the cholangiocyte to go for the further activation. So this sequence circle will go on, which I understood. I am coming just now for the LPS, beginning of the slide. It all depend upon whether it will be the repair or resolution. It all depend upon the pro-inflammatory cytokines. If it is a more of IL-8, more of CX3CL1, more neutrophils will go there. And neutrophils will make the cholangiocyte activation again and again. That's they are saying. And they are making in the alcoholic hepatitis, worsening of the disease due to the neutrophils. And in the end, they have even said that if you cut down the neutrophils or deplete the neutrophils, there may be the recovery. But those experiments, they did it in the mice, not in the... Till here, in this, they said that the granucolizing neutrophils are making the more cholangiocyte ductular reaction proliferation. And even in another manuscript, what they took it that again the alcoholic hepatitis, and they made the organoids from the healthy and from the AH, and again they did the keratin 7 and the APCAM, and then they did the single cell sequencing in the organoids and the liver tissue. In the organoids, again, they have shown that the CXCL1, CXCL3, all chemokines, ligands, and the CCL20 and 28 was increased along with the APCAM and the keratin 7 in the organoids from the alcoholic hepatitis patients. And then they did the RT-PCR, delta C, and then they showed that these chemokines were more. And in the alcoholic hepatitis, what they did in this, please see, that they have used in the, simultaneously they have created the mice model, and they give the inhibitor of NF-kappa B and IL-1 beta inhibitor also they have used it, but still they were seeing that the CXCL1 instead giving the stimulus of IL-1 beta and inhibitor, still it stays there, CXCL1, and CXCL6 also was even giving the inhibitor of NF-kappa B and IL-1 beta, still it was there because neutrophils need these chemokines for the recruitment, and they did it for the organoids and the liver tissue. Again, they have shown that the keratin and MPO, and then again they have shown that in the liver organoids, these are the liver organoids, they have made the organoids, and there was a neutrophil concentration was much more. Even they used the conditioned media of the organoids to regenerate the other organoids, and they have shown that the percent neutrophils were much more in the conditioned media LPCs or the liver organoids, and those all liver organoids again made the more of the CXCL1, CXCL2, TNF alpha, IL-1 beta, and all the chemokines. Now the story they showed it here, that in the first manuscript where, sir, that summary slide was there, that the neutrophils are making the cholangiocyte activation. There only they have shown in the mice model that if you do the long-term depletion of neutrophils, there is a decrease in proliferating biliary epithelium. They did it in the mice study, and they used the isotype and anti-Ly6G. Anti-Ly6 is the antibody to the neutrophils, you can say. And they have shown in that MPO was decreased here. Similarly, keratin 19 was decreased, and they just redundant figures, which is showing that with the anti-IL-6 MPO was decreased, and MPO is the marker of the neutrophils. So if you deplete the neutrophils, there could be the less of the proliferating biliary epithelium. So in the nutshell, they are saying that during the ductular reaction, there are the DRANs, like the neutrophils, they have the long-lasting retention power in the injury, which makes the injury progression. They have the altered phenotype and functionality, because from CXCR2 to CXCR4 they make it, which makes the ROS production, and phagocytosis is becoming the less, and the L-selectin is also going down. Third is the induction of ductular reaction proliferation. When the nets are more, there is more of the ductular reaction in this. Now, as the madam only gave me the neutrophil, but I coming to the nepheld, which is another different story. It's not the neutrophils. So ductular reaction in the nepheld, how it works. There is a excessive lipid deposition, we know, and associated with the obesity and metabolic syndromes. So what happened in the healthy, there is a normal biliary epithelium, and if you see the NASH, there is a peribiliary fibrosis, inflammation, mast cell activation, lymphocyte infiltration, and scar tissue, and in the NASH end stage, there is a hepatocyte apoptosis and chronic, because there is a more of the deposition of the fat. So what they did, even in the pediatric NASH patients, they said that present with the portal fibrosis correlated with ductular reaction and HPC proliferation. And even they said, this is also a redundant slide, I will say, that there is a similarity between the NASH and the cholangiopathis due to cholestasis, bridging fibrosis, ductular reaction, hepatic inflammation, and so on and so on. But what they did, that in nepheld, what they say, that healthy cholangiocyte acquires the two different kind of phenotypes. One is the neuroendocrine phenotype, and another is the senescent phenotypes. In the neuroendocrine phenotype, they start having that neuro hormones and neurocytokines, and in the senescent, they start expressing the P1621 and so on, senescent cytokines. So there is a mechanism of ductular reaction in NAFLD, because generally bile acids and the cholangiocytes have the more expression of CYP2 and TGR5. Bile acids are coming, and there, through the FXR, there is a hepatic bile acid reabsorption phenomena. However, in the NAFLD progression, when there is a more lipid deposition, bile acids are going up, staying more, because there is a CYP2 and TGR5 is reduced. Due to this reduction, there is a hepatic bile acid reabsorption is very less. So they said that in NAFLD, this kind of, as I told you, they have the altered phenotype. There is a neuroendocrine phenotype in the nepheld. And what happened in the increased neurohormones in the nepheld, which they have shown that there is expression of secretin receptor, which is becoming less, and due to that, I must say that this whole story also shuffles between the small cholangiocytes and the large cholangiocytes. Nepheld is more of the large cholangiocyte story, and this large cholangiocyte proliferation makes the peribiliary fibrosis and inflammatory responses. I will go with this, that the steatotic patient present with the increased bile duct mass, they have shown cholangiocyte-derived factors as key mediators of hepatocyte steatosis, HSC activation. ductular reaction and biliary hyperplasia at the NASH stage. Due to the modulation of the bile acid signaling CYP2 and it becomes the NAFLD, and inhibition of secretion or histamine signaling could prove therapeutic for the NAFLD patient. They have even recommended that antihistamine should be taken because the antagonist histamine receptor antagonist can concurrently be purchased over the counter for general allergies. It could be used for these drugs for the beneficial for the NAFLD biliary things. So how biliary senescence contribute to the liver diseases? Because the biliary small and the large cholangiocytes, they go for the, especially in the PSC and the PBC, there is more of the senescence. I'm not just elaborating because I have one very beautiful manuscript. What they did is differently. So I'm just touching upon the role of macrophage in the ductular reaction. The other first two mechanisms were different, but here it is more of macrophage's story. Especially as I told you, as instead of IL-8, they start secreting the reactive cholangiocyte in the presence of lipid. CXC3L1, MCP1, MIP3 and the MIG, which creates the more of Kupffer cells, monocytes and the dendritic cells. What happened that in this ductular reaction, they have just made that generally indirectly hepatic progenitor cells, when they differentiate into the cholangiocytes, and these cholangiocytes, when they are activating, they are making the more of the fibrosis, and in this way there may be the notch and the hedgeway pathway is promoting the differentiation. However, and again this story they says that indirectly they are contributing into the hepatic fibrosis because hepatic progenitor cells are coming into the cholangiocyte and they are making the more of fibrosis. But the story here is very beautiful. This is the hepatology, J hepatology, Frank Tackett group. They have recently, just 2023 and coming in 24, they have mapped the hepatic immune landscape with the monocyte macrophages as a key drivers for the steatohepatitis and cholangiopathy progression. I will just come. This is a very interesting story, and this is a crowded slide. However, they have just given one concept that macrophages CD163 positive and IBA1 positive. IBA1 is a calcium channel receptor on the macrophages, generally on activated macrophages or microglia, these are expressed. So they said that if you see the normal, NASH and the PSC, because PSC they have just taken as a positive control. So IBA1, which is a red in the color, please see, and MPO, blue color, CD8, CD4, HepAR1, CK19 and DAPI. So only the red color is coming in the NASH. So this is the beginning slide, and they have just shown that if you go to this D slide, that IBA1 is a fibrosis. 1, 2, 3, 4 are the 4 stages of NAFLD and NASH here, these 4. So in the F4 stage, IBA1 was the increased significantly than even the PSC. Next slide, what they did, they showed that this was just to show you that what is the IBA1. So in the next slide, again they did it normal, NASH, PSC, and then they have taken CD163. So if you see that CD163 is red in color, red spots are more here, and CD163 macrophages, if you just see the cell counts per millimeter square total tissue. So parenchymal there was less, but in the periportal area it was increased. Similarly, CD68 macrophages was increased in the periportal. Red is the F4 NASH. So in the F4 NASH, the CD68 macrophages were more. Again, they did in the third slide, they have used the IBA1 and CD163, and if you can see that the IBA1 and in the NASH, the CD163 was the most. So they concluded that in the NASH and NAFLD, instead of the neutrophils, there is a role of macrophages in the Yes, in the ductular reaction. And even they took the PSC non-severe, PSC recurrence, and then they have taken the severe alcoholic hepatitis. Now, this is the most interesting story, and that in severe alcoholic hepatitis, they showed that in non-severe and the severe, there was a more of the CD163. So I am just running through the slides. So this also shows that in the NAFLs, there is more of fibrosis due to the ductular erection, but this ductular erection is happening due to, and playing the role of the macrophages. So I will just touch upon
Give
one
me a
slide.
Summary slide, please.
So summary.
You are run out of time.
Okay.
Just give you a
So
last.
this is my summary slide. So madam, this is the CLD, the healthy liver, there was a bile duct, there was nothing. But this is the ALD, where is the neutrophils are more. HBV and HCV lymphocytes are more, and in the NAFLD, there is a more of the macrophages story. So this is the end, I will say. Thank you so much.